and growing area of concern for infectious diseases. And before we start, I would like to respectfully acknowledge the traditional owners of the land, the Wurundjeri people of the Kulin Nation, and we pay our respects to elders past, present, and emerging. So we'll be recording this session today, and each speaker will have 13 minutes plus 2 minutes for questions. And I'm sorry if that's a bit jam-packed, but we actually wanted to cover a number of topics today, and our speakers have gracefully agreed to give these very intense short talks. I will give a warning if we're going a little bit over time, just to keep everything on the straight and narrow. And I think it's really wonderful to have these 5 excellent speakers today, and speakers who've been involved intimately in the area of infections in the ICU, including involving in the most recent ECMM global guidelines for candidemia published in the Lancet, which was Sharon and Lewis being involved. And of course, Jason's work with antifungals in the ICU is also really important. And not to mention Elise, who's done some very interesting work on fungal infections in the ICU, and Professor Ignacio Martin Loches, who's our last speaker, who'll be talking about trends in infection in the ICU. But now to open up, I'd like to introduce the first speaker, and we're very lucky to have Dr. Luis Ostrosky Zeichner, who's a professor of medicine and epidemiology, a Memorial Hermann Endowed Chair and Vice Chair of Medicine and Laboratory Mycology, Director of Mycology Research, and the Division Chief at the Division of Infectious Diseases at the McGovern Medical School in Texas. I'm getting a little echo there. It might be the recording. Shall we double check? We're good now? Yeah. So, no, we're not. We're still getting an echo. Let's see. Okay, I think we're good. So I would now like to hand over to Professor Luis Ostrosky Zeichner, our first speaker, who's going to talk to us about Candida in the ICU, recent updates on epidemiology, risk factors, and infection characteristics. So really looking forward to your talk, Luis, and thank you very much for joining us in What's Your Evening. Over to you.
Thank you very much, Professor Slavin, and thank you to the organizing committee for this opportunity. I would absolutely love to be there in person. I love Australia, but we have to settle for Houston. I'm going to share my presentation. Perfect. So over the next few minutes, we're going to be discussing Candida in the ICU with recent updates in epidemiology, risk factors, and infection characteristics. These are my disclosures. I do work with multiple companies that are investigating antifungals and new fungal diagnostics. So I always like to start with patients, and I want to share this case that we recently published at ID Cases. This is a patient we saw at Memorial Hermann Hospital. Our hospital is a quaternary care center, very high specialty, and we have a very, very active heart transplant and advanced heart failure program. And as you can imagine, some of our more challenging cases in Candida are really the LVADs. And I really like to feature this case because it's an example of how the candidemia we're treating in 2026 is not your father's candidemia. This is not simple line related where you pull the line and you're almost done just by pulling the line. You go antifungals, you're done. No, the cases we're seeing nowadays are much more complicated. So this gentleman had his LVAD placed in 2021. He had 2 good years without infections. 2023, he developed his first driveline infection with MSSA. 6 months later, he was admitted for Candida auris sanguinea that was detected in the outpatient space. He was treated with micafungin. He was discharged on micafungin, and he had a breakthrough infection. He was readmitted. We kept him in the hospital for a while, and then we discharged him with the plan to start him on risafungin, which was the newest echinocandin, and obviously with the possibility of administering once a week in the outpatient space. He did well for about 5 months on the risafungin, and then he broke through again with Candida auris. At that point, we admitted him and put him back on micafungin, re-induced him. He was doing okay, and then we tried PO posaconazole. We know we're not supposed to do azoles when fluconazole is resistant, but he did have a, in theory, treatable MIC. So we gave it a try, and of course, he relapsed. The patient was readmitted with an extensive bucket infection this time. He went IND, and then we put him on risafungin for 6 weeks and put him on posaconazole again. And this is a PET CT where you're seeing the activity around the LVAD pocket, which again, it's one of our new modalities. You can see the MIC progression there. The MICs really didn't change, and we were convinced that this was not a resistance failure or susceptibility issue. It was really a retained foreign body concern, which is by far the most frequent reason people fail treatment for candidemia. So how did we get to this case? Well, Candida is starting to be a major problem. I'm going to respectfully comment on the epidemiology of the US because that's what we know here. Candida is the most frequently seen fungal infection in US hospitals. It accounts for about 26,000 hospitalizations per year, about 3 million hospital visits, most likely not invasive disease, with 3 billion excess cost when we're treating Candida. So you can see this is clearly a public health issue. As far as actual healthcare associated infections, this is data from NHSN, the benchmarking system that we use to monitor HAIs in the US. And Candida sort of flips flops between the first and second most common cause of bloodstream infections in the US, second only to Staph aureus. So again, definitely a public health issue and a big priority when you're working in the ICU. Some notable epidemiological trends. This is the new world map for resistance. We took this out of a publication, Nature Reviews. And this little map tells you number 1, 2, 3, 4, and 5 as far as the most frequently seen Candida species in each region of the world. And you can see that for the most part, if you're working in North America, it's going to be the usual Candida albicans or glabrata second, then perhaps losas, then tropicalis, and then cruciae. But if we move to the Pacific Asia region, which is where you're fortunate enough to be, the epidemiology of number 2, 3, and 4 changes dramatically. The other thing we did in this map is mark the countries that have reported Candida auris, the countries that have reported fluconazole-resistant Candida brucellosis, which is the other emerging Candida species, and of course, the countries that have both. So you can see there's coloring in most of the world map, and actually the places where we don't have any coloring are the places where we don't have epidemiological information. So again, this is the new epidemiology. And sort of up front and center is the emergence of Candida auris. Like I showed you in my case, this is kind of the perfect pathogen because not only can it be multi-drug resistant, off the bat resistant to azoles, sometimes resistant to echinocandins, sometimes to amphotericin B, and occasionally resistant to multiple Candida species. Not only is it a perfect pathogen from sort of the susceptibility problem, but it transmits incredibly well in the hospital. So it's like what I call the Acinetobacter of the Candida world. Once you establish Candida auris in a unit or in a hospital, it's incredibly hard to eradicate. Hot off the press, we just did a review of the Candida species causing candidemia in the US. This is work with my colleagues at the CDC. And big news is that Candida glabrata now is the most frequently seen Candida species in the US. And this is going to matter a lot because of a slide that's coming up. And Candida auris makes a debut in number 5. So it is now the 5th most common Candida species in the US. I will share that in my hospital, Candida auris is the most frequently seen Candida species at this point in time. We've done a lot of work to control Candida albicans and glabrata, and we keep having introductions of Candida auris from the community that we're sort of fending off, but it is clocking in at number 5, nationally number 1 for my hospital. A very important trend to watch, and this is why the previous slide was important, is because every now and then we hear of echinocandin-resistant Candida glabrata. And this so far appears to be a clonal phenomenon where one of the clone establishes in your hospital and you see it. But nevertheless, Candida glabrata would be resistant to the number 1 treatment recommendation in the guidelines, which is echinocandin. So while it appears to be a isolated incident in certain hospitals, this is definitely something we're watching very closely. So turning on into classic epidemiology, we need to sort of discuss risk and who gets candidemia. So the classic risk factors for Candida infections are very well described. There's this punch list that I have for you. Number 1 risk factor is Candida colonization, particularly if multifocal, gastrointestinal surgery or perforation, solid tumors, presence of a central venous catheter, use of central broad spectrum antibiotics, transplant recipients, both solid organ and stem cell transplants. Within this group, stem cell transplant is one of the main risk factors, and among the solid organs, we're primarily concerned with candidemia in the liver transplant patients. Use of steroids and other immunosuppressants, being in the ICU is a major risk factor, diabetes for pediatrics, prematurity and low birth weight, pancreatitis with infected necrosis or not, neutropenia, older age, and then from the community, we're starting to see people coming with injection drug use as one of the major driving risk factors, along with hemodialysis. Again, mechanical ventilation, LVADs as a sort of novel risk factor, mucositis, TPN, and of course, everything is COVID. So during the COVID pandemic, we noticed an increased incidence of Candida, and this was a very clear risk factor for this disease. So the big question is are we talking about risk factors or mechanisms? And actually, it's both. So I think with some of those risk factors that I showed you are just barely, markers of the severity of illness in the patient and the severity of immune dysfunction or gut permeability. And some of those are related directly to the pathogenesis, like a central venous catheter or an LVAD. Anyway, the pathogenesis of Candida has been studied extensively, and basically there's 2 ways you can get candidemia: by translocation of your gut flora or by introduction from the outside through a central venous catheter. So these are the major drivers, and there's all sorts of virulence factors that are in play and host factors as well. So the big question for me has always been, the thinking has traditionally been you get your own Candida species, the one you're colonized with. And well, a few years ago, we did an analysis in my hospital. We're just really doing kind of a basic, hey, this is our epidemiology for Candida, looking at who gets it, Candida species, as you can see here, pretty standard, Apache 2 score high, extended length of stay, crude mortality about 20%, mostly in the ICU, mostly Candida albicans. Resistance was rare. But we did an extra little thing in this study, which was DNA fingerprinting. And lo and behold, we found that about 26% of isolates in our hospital were related to another isolate in the hospital. And when we sort of matched them up, we found out that we had 11 clusters of 2 to 4 isolates occurring in the hospital. So this really opened my eyes as to, moving away from Candida as an endogenous infection and thinking about it primarily as a hospital or healthcare associated or transmitted infection where other strains that are present in the hospital may be colonizing you, and then that's the one that you get. Are there ways to assess risk objectively? We've made a career here in my lab about risk factor prediction and prediction rules. This is the rule we use for our caspofungin clinical trial. This was derived from a retrospective chart review of 600 back then contemporary charts. We were using classic risk factors and mechanical ventilation, and we wanted to play around with risk factors and come up with a rule that would roughly apply to 20% of patients, or no more than 20%, with at least a 10% incidence of Candida and with a relative risk of at least 4. And what we came up with is shown on the right-hand slide, which is mechanical ventilation, central venous catheter, and broad spectrum in the first 3 days, with one of the minor risk factors like PTN, dialysis, surgery, pancreatitis, and steroids or other immunosuppressive agents. So again, if you use this rule, you can guarantee at least a 10% incidence of disease. As far as outcomes go with candidemia, I have some mixed news to report here. This is really head-to-head all the clinical trials that we've done over the years. This, predates me for sure. This is data starting in the 1990s. And as you can see here, mortality, all-cause mortality used to run in the 30s and 40s. And slowly but surely, we've been running it down to the 20s to 30s. But I think you'll agree with me that there's a lot of room there because, again, to this date, 1 in 3 patients with candidemia or 1 in 5 are going to die from this disease. So I think we have a little wiggle room with antifungals, but also with host-directed therapies. I think we have some opportunities there as well. So back to our patients. So remember, our patient broke through on micafungin, and at that point, we did the only thing we could do, which is old school, Ambisome and 5-FC. The patient was started on that. After 2 weeks, he broke through again. He was persistently fungemic for 3 weeks, despite now trying Ambisome, 5-FC, and micafungin. And at that point, we concocted a plan, kind of a last resort plan of taking out the LVAD, putting the patient on an Impala, which is a very temporary measure, to bridge the patient to a new LVAD and potentially a transplant. So we did that. We extracted the LVAD, put him on an Impala. During that time, we decided to try fosmanogepix because the MIC was 0.008. We achieved negative blood cultures. I'm not sure if it was fosmanogepix or the source control. We treated him for sort of deep disease with 6 weeks of fosmanogepix, put in a new LVAD, and put him on the transplant list with the highest priority. Unfortunately, the patient relapsed after 6 months and eventually passed away. So again, not always a happy ending, a lot of interventions done for this patient, but at the end of the day, it's a lot about source control and seeding throughout the body. So at the end of the talk, I hope I impress upon you that Candida is a significant problem in healthcare settings. We have a changing worldwide epidemiology. We discuss the risk factors that reflect both host and pathogenesis. And although we've improved mortality slightly, cases are becoming more complex, and we have a lot of work to do coming up ahead. And in my last slide, I'd like to take this opportunity to let you know it's not too late to register for the MSG ERC biennial meeting coming up in September in Denver. A lot of good Australian representation, but we hope to have more. So again, thank you for your attention.
Thank you very much, Luis. That was an amazing talk, bringing us really up to date on epidemiology of Candida